Next is Amy Nichols. Amy is Director of Hospital Epidemiology and Infection Control at the University of California, San Francisco. She's certified in infection control and was accepted or designated a fellow of infection prevention in 2016 by APIC. She has a master's in business administration from Golden State University. She served as both president and chapter legislative rep for the APIC San Francisco Bay Area chapter, and she currently serves on the APIC Practice Guidance Committee. And Amy says that she's been learning infection prevention since 1996 and continues to be surprised daily. Amy will share with you the essence of the infection prevention toolkit that has been, and the expert committee that has brought that forward.
Thank you. Well, let's try not to add to Roy's discomfort tonight. And we'll try to add an opportunity for you to apply some standardization and reliability to probe use. I am Amy Nichols. I work at the University of California, San Francisco, and I wanted to give you just a little bit of background about that organization because I'll refer to it later and you'll understand why this is revealing. It's about a 1,000-bed, 3-campus facility. We have about 225 ambulatory clinics, and we include a children's hospital as well as adults. Is that the right thing to push? No? Oh, gosh.
2 out of 3.
Yeah, I'm going to get the technology up here reliably and in a standard format. How did we get here? Along with the challenges of ultrasound use and processing, we find there are differences in recommendations and in how our regulatory and accreditation colleagues apply those recommendations, right? Right. That leads us to the second bullet, which is how we address the variation in policy and practice gaps as reported by you and your colleagues, as Roy mentioned, real patient safety risks, and knowing that we do not live in a sterile world. So these knotty problems require practical solutions that you and I need in order to hold our facilities to a high level of safety. The contributors of the toolkit, as you see here, are real practicing infection preventionists, just like you. So we don't have any secrets. We live the same lives that you live. I was going to use an expletive, but I deleted it. The IP toolkit for probes contains 4 tools designed to help us locate ultrasound machines, assess how they are used, provide guidance for how they should be used, and a structure for developing your own institutional and departmental policies. The toolkit mirrors a process my team, who's sitting in the back, they thought they could get away from me, but they can't. My team used several years ago when we embarked on the journey of identifying every flexible endoscope in the organization, cataloging those, putting them in a database, and putting in a process where they are evaluated and attested every 6 months by their owners. Yeah, and it works. That was an eye-opener, let me tell you, and the journey to locate, assess, and add procedural rigor to probes promises to be just as adventuresome as that one was. All the tools in the kit are editable, so you can tailor them to your own situation, and the checklists ensure that, that we are being comprehensive. There is room for you to add your own local requirements, policies, guidelines, recommendations, so the tools are relevant for your institution as well. And finally, the 4-tool kit is designed to use your time efficiently. Oh my gosh, doesn't that sound great? That is not to say it will be quick and easy, however. I'm expecting it to take about a year in our institution. I haven't told my team back there that yet, but I'm just done it. But it is comprehensive and organized. Okay, you can, if you have your electronic device on you, you can go ahead and access, I think, right? Yeah, it's live. You can go ahead and access the toolkit right now, right here, right now, and you can go through it with me as I'm going through it. You can get on it and become a member. The toolkit is free, and the tools can be downloaded as one complete zip file if you'd prefer, or you can download each tool individually, however it works best for you. And when you sign up, you can opt to get notifications for when there are updates or when new tools are added. So I'm going to encourage everyone here to go on to start using these tools because I would like you to give feedback. What we know is that we don't have the last word on this process. And the world of probe use and reprocessing is likely to expand as we begin sharing our findings and discoveries. So you can help. Okay. There are 4 tools. The first tool has part A and B. Part A is to locate where are the ultrasound machines and probes in your institution. How will you discover them? Yes, you will discover them. Are they mobile and shared among departments? Are they purchased by individual departments, or are they completely uncatalogued? Oh, well, you will find out. Part B is profile. After locating the machines, this audit tool is used to observe and assess ultrasound practices as they are used in your various departments. And as Roy said, they're used every which way and in places where you will be surprised to find them. Working through the profile form is intended to help you record actual practice, leading you, the observer, to an action plan as necessary. All right, then we go to tool 2, the algorithm. This tool is organized by department and provides a range of typical procedures that may happen in that department. The displayed probe use and reprocessing requirements are based on CDC guidelines, as we've heard, and AMI standards. So those are displayed as a decision-making tool and flow chart that can be printed and posted in the various departments. And there's a tool for each department that we could identify where they're used. Tool number 3 is the risk assessment, and the templates are designed to guide you in assessing potential hazards that may be encountered along the life cycle of the probe. And that is during use, cleaning, reprocessing, and storing. The risk matrix can be used to help identify how to mitigate to the lowest risk possible. And if risk remains higher, then you might want to reconsider some of your processes. Oh my goodness. Tool number 4. Can you see, this is really going to be fun for all of us, isn't it? Job security. The tool number 4. Policy development framework can be applied to all settings where ultrasound is used and reprocessed. And this can be applied to an institution or a department, however it will work best for you. All right, so I wanted to get into the tools a little bit more deeply to give you a flavor of what you're signing up for. You didn't know you were be strong-armed into signing up. No, I'm just kidding. You can do this if you want, and you don't have to, but it would be a really good idea, and it would be helpful for your organization. The toolkit provides 4 strategies in Part A for locate. 4 strategies for locating where your ultrasound machines might be located. In our experience with the scopes, we used all 4 of these strategies, and we didn't find all of them, but we found the majority. And I think all 4 are necessary to find the majority. First, you'll work with your biomed or clinical engineering, however you call them, supply chain and material services folks to develop a list of locations that have purchased ultrasound machines. So this is somebody else's work, and they're just going to hand it over to you. It's great. It's great. So biomed or clinical engineering will likely have information about the hardware. Be aware that if individuals or departments purchase equipment outside of that strategy, outside of purchasing, then they may not appear on that list. Okay, second, and this isn't on here, but if you're following along on your electronic device, you'll see it. Second is to work with your supply chain folks to develop a list of locations that purchase or stock ultrasound gel in whatever form it comes in. That list will help in a few ways. One, you'll be able to identify locations that stock the gel, and therefore they are likely to use one or more ultrasound machines. Compare that list with the location list that you got from biomedical engineering, and then you'll see where some of the gaps are. When you're assessing for appropriate practice, knowing which locations have sterile gel and which have non-sterile gel will likely help you understand whether they need our help, in adjusting their practices. Third, you'll survey departments where ultrasound is usually performed. They may have other ideas about where ultrasound is used. I know that when we were working with the scopes, people would tell us, oh, you know, the department down the street has another scope. Did you know that they're using the same type we are? No, we didn't know that. Thank you very much. There are other strategies to get the word out. If your institution allows organization-wide email, you can send out an email that says, we're looking for all ultrasounds. Please let us know if you have one or if you stock gel. And then you can compare that with the first two lists that you've received. At UCSF, we like to get in front of the patient care managers and directors because they usually know where the bodies are buried and where the ultrasound machines are located. So finally, the last strategy, the fourth strategy, is to partner with your health information management teams and finance. Health information management can tell you what ICD-10 codes are being used to code ultrasound. It's a billable procedure, so of course they're going to be able to tell you how they code it. And then finance should be able to give you a list of the providers who use ultrasound or who are billing for ultrasound, and then you can work with them to figure out where those machines are that they're using. Okay, so that was, oh, no, one more. I wanted to show you, I asked our supply chain and clinical engineering to send me their lists. This is the one from supply chain. It's just a snapshot of many pages of places where ultrasound is used. And you'll see there are 11 places where sterile ultrasound is used in the 20-gram pack. And I think there are probably more places at UCSF that should be using sterile gel. We'll see as we go through this process. All right, Tool 1, Part B is to profile. This is not a bad word. So once you have located the ultrasound machines, use this tool to observe. You will go to the places where ultrasound machines are and observe how they're being used. And then you will record on the editable tool that is provided. The tool will help you determine whether the practices you observed are aligned with best practices, your own policies, and patient safety. The tool leads the observer to an action plan if there is no policy or if practices do not align with the policy. All right, so here's just the top half of the profile tool. It's a snapshot, and it demonstrates the flow for the location that has a policy guiding this example is for a place that has a policy that tells the people how they're supposed to use their ultrasound. If there is no policy, then the shaded area will be marked, and you'll go to tool number 4. You'll just go right forward. So in this example, there is a policy. The policy addresses the reprocessing practice and the type of sheath and gel used. So now your next step is to check the manufacturer's IFU for that probe and make sure that the policy aligns with the IFU. All right, and if it does, then you're going to mark yes, and if not, you've got another partnership forming. All right, this is the second half of this tool. This takes you through the practice observation. So how is the ultrasound probe handled in real life? In this example, you'll recall the policy calls for high-level disinfection, a sterile sheath, and sterile gel. In practice, however, high-level disinfection is used. However, no cover and non-sterile gel was used. Therefore, number 5 is marked as no. And if there are any shaded areas on this page, you will develop an action plan with your partners in the place where they're using ultrasound. And in this example, it does show the beginning of an action plan. All right, tool 2 is the algorithm. It's based on the Spalding classification, as Roy was describing before, and I'm going to describe again. Referenced by the CDC, by CDC guidelines, AMI, ANSI, CMS, and Joint Commission. This system dictates that the level of disinfection or sterilization a device should be subjected to is based on the degree of infection risk associated with its use and contact in patients. So just to remind us, non-critical devices only contact what? Intact skin. Very good. They do not penetrate the skin. They do not touch mucous membranes, and requires what kind of disinfection? Low level. Very good. See, the coffee's kicking in. And this includes things like blood pressure cuffs, side rails, and so on. Non-critical ultrasound use is limited to external scans across healthy skin. All right, semi-critical devices contact non-intact skin and mucous membranes. Very good. Okay, and require what kind of disinfection? High-level disinfection. Very good. Okay, so semi-critical ultrasound use includes endocavity scans, like transvaginal, transrectal, and those that occur on non-intact skin. Critical devices enter or contact sterile tissue or the vascular system. You guys are so good. I wish I had some candy up here to throw for you. But no, I don't want to. Yeah, there's dessert after we talk.
Took my line.
You know. So you're all winners. All right, so critical ultrasound use includes when ultrasounds are used in, ultrasound probes are used in interventional procedures, surgery, IR, and when used to guide percutaneous procedures where contact with the puncture site is possible. Ultrasound-guided biopsies, injections, cannulations, central line insertion. So but as Roy mentioned, CDC gives that caveat to you can have them undergo high-level disinfection if they can't tolerate sterilization. That said, the use of a sheath does not negate the requirement for high-level disinfection. I see heads nodding. Okay, here's a picture of the algorithm. We're going to use the OBGYN maternal family medicine as an example. So a transvaginal ultrasound is used. And this tool is, and that use is categorized as semi-critical. So it requires what kind of disinfection? High-level disinfection, and according to this, a clean sheath and a single-use gel. Sterile is preferred, but you can go with clean. You'll recall from the profile exercise that the policy met all the criteria, however, practice did not align with the policy. This tool and the others in Tool 2, for all of the places where we could think of that ultrasound was used, can be posted for reference in the location where the procedure is being done. And as you examine Tool 2, you'll check to see if your institution has these departments or others not included, and you'll let us know. All right, Tool 3 is the risk assessment. It provides 4 editable templated risk assessments for probe cleaning, disinfection, storage, and use. You can combine and edit the templates to complete a full risk assessment for your organization. And you'll use the risk matrix provided to determine the risk rating for each hazard, rate the likelihood and severity for each hazard, and that will help you determine its overall risk rating. So example mitigations are provided and are designed to reduce all hazards to low risk. If a mitigation cannot be put into place, the existing workflow or your products or policies should be reconsidered. So here's an example. This is the risk table provided in the tool, and the likelihood is down the left column. The severity is across the top. So let's say that we had something that was risk that was possible and the severity was moderate. We would come out with a medium risk. We're going to see that in just a second, as soon as I hit the thing to go forward. In your risk assessment, you've determined that the cleaning agent or process is not deemed compatible by the manufacturer's IFU, and possible harm is documented. The likelihood of harm that we said was likelihood is possible, and the severity is moderate, so we've got a medium risk. If the mitigation of selecting a cleaning agent approved by the manufacturer's IFU is put into place, the risk after mitigation would alter and would become low. All right. And tool number 4, policy development framework. This is one I love, I have to say, because it helps me not have to think quite so hard. It provides an editable framework for policy development in any setting where ultrasounds are used. The template is based upon United States guidelines, standards, and evidence-based literature. And this generalized document can be modified to include specific regulations, guidelines, policies, procedures for your region, institution, or department. Here is a snapshot of the table of contents. All aspects of probe use and reprocessing are addressed in the policy template, including cleaning, disinfection, sterilization, storage use, responsibilities, education, and training. All right, the policy framework is fully referenced, as you can see here. Isn't that lovely? So nice. It's designed to answer the questions from those inquiring minds that may not agree with you.
Who are those?
I don't
There aren't any
know.
of those. I don't think there's anybody either.
Also within the document are these blue boxes that provide you instructions that you as the IP and your colleagues in the organization can customize. So isn't that easy? Isn't that lovely? I do want to touch on traceability. Rose is going to talk much more about this, but I'm going to give her a little intro here. One critical aspect of the policy is ensuring that you and others in your organization can trace the life history of the probe, from when it arrived, everybody on whom it was used, how it was reprocessed and stored after every use, And the requirements are discussed in this section of the policy. All right, so did we hit our objectives here? I think you'll agree that the toolbox addresses the challenges to ultrasound use and reprocessing, variability in recommendations, and how accreditation and regulatory agencies interpret them. The toolkit can help us address variation in policy and practice across the organization, can address practice gaps that you and your colleagues have reported, help us mitigate patient safety risks, and all of this knowing that we do not live in a sterile world. The toolkit, I think you'll agree, provides solutions that you and I can implement in order to hold our facilities to a high level of safety. And now I'm going to turn it over to Rose.